changing lives.
Good evening, lovely viewers, and welcome back to another interesting episode on the Consulting Room. We're happy to have you again. Thank you for joining us every Monday from 8 to 9 p.m. We come to you live from the studios of Hope Channel, Ghana. And on the Consulting Room, we bring you all the latest updates and tips on your health. I'm Dr. Na Ayika. Last week, there was a video that was trending on social media. Maybe it's because it was from one of the influential people in Ghana. And in summary, the person said he had been diagnosed with G6PD. And as you come to know later in the show, there are some dietary restrictions and medication restrictions. So he had been given some medication, which he later came to realize about taking it for about 6 months, that he wasn't supposed to be taking that medication because he had been diagnosed with G6PD. There was a lot of noise about it on social media, but I found some comments on the video that were quite disturbing. There were people who hadn't even heard of G6PD before, who didn't know what it was, were asking, are you born with it? How do I get it? And clearly they didn't know their statuses. So tonight on the Consulting Room, we're talking all about G6PD, Glucose-6 Phosphate-Dehydrogenase Deficiency. It's a very long word, but tonight we're going to simplify it for you. So if you have any of these questions on your mind and you need answers to them, please stay tuned on the Consulting Room. So with me to simplify this condition, I have with me two special guests. They are no strangers to the Consulting Room. If you're loyal to us, you would have seen them on a couple of our shows. So I have with me ASP Dr. Kweku Animedu, and he's a medical officer with the police hospital. Dr. Animedu, you're welcome.
Thank you very much.
Welcome back to the Consulting Room. And also we have Dr. Emmanuel Adipa Adapo, a medical officer with the Greater Accra Regional Hospital. Doc, you're welcome back to the Consulting Room.
Thank you.
It's good to have you both join us for such an interesting discussion. So we'll get into it shortly. We'll take a quick commercial break, and when we get back, we'll get into the discussion. Please join in this conversation, send in your comments and questions. We'd love to hear from you. Please stay tuned.
Michael and Ernest, in Luke chapter 10, verse 38 to 42, it talks about Mary and Martha while Jesus visited them at home.
Yeah.
What's your take on Jesus' response to Martha, that Mary had chosen right? Ernest.
Okay, for me, I think it's about priority. Okay. Mary decided to sit at the feet of Jesus and listen to the word of God, while Martha chose to be in the kitchen and cook.
Okay.
I'll beg to differ. I think they needed the food to get the energy to have that discussion in the first place. So from that perspective, I think Martha chose right.
Well, I'm not trying to say that Martha didn't choose right, but what I'm saying is it's about placing God first.
Chaplain, what do you think about what Ernest is saying?
So like Michael, Ernest, and Finley, this is why you need to join us on Hope Bible School. Here is where we study the Bible to understand what it truly means. You also get to ask all the questions that bothers your mind, from politics to health to doctrine to anything that is bothering your mind. We have introduced a segment in the program which we call the SACS moment, which is simple answers to sample questions. And so we will answer all your questions for you. What is more, we also get to treat you with beautiful music from our array of musicians that we have. And so join us on Hope Bible School and let's study the Word of God together.
to the consulting room. Tonight we're talking all about G6PD. It's a very long name, but we're going to simplify it for you. So please stay tuned. Dr. Anyimedu and Dr. Adapo, you're welcome again to the consulting room.
Thank you.
So I'll start with Dr. Adapo. G6PD, what is it?
Well, like you said, the controversy this thing generated, many people think G6PD is actually a disease, but it is not. It is an inheritable disorder. So let's say, for instance, all our names, my name is, so let me take the Adipa, right? It is spelled A-D-D-I-P-A. And that is, let's assume that is how the G6PD code is supposed to be written, right? So if my Adipa is to be ADDIPA and then the G6PD will be present and be active, then it is spelled ADEPA. And that is also Adipa. However, there is a substitution of the names, and so that code, even though it has written Adipa, will be inactive. So when that happens, it happens on the X chromosome.
Okay.
So it means that men who are XY, to be a man, you have to inherit an X from your mother and a Y from your father. So if the X chromosome of your mother has that misspelled arrangement for the protein that codes for the G6PD, then you are going to be G6PD defective.
Okay.
So that is a disorder that exists. But many people are asymptomatic. So you will not even know until the restrictions that you're supposed to undergo start causing their effects or their consequences. Then you begin to know. So it's I'll say it's a genetic disorder. It's inheritable from both parents. But men are more affected than women because we have only one X, which means that women who are XX, if the woman has one defective chromosome, the other can compensate for it. So they are usually carriers. They don't show the effects as much as the men will show.
But are there different types of this
There are many different types. In fact, there are more than 186 documented types of the G6PD. And meaning, I mean, the mutations, very different mutations. So we say G6PD is a polymorphic disorder. It means that there are so many different types. There are so many expressions that they exhibit. And therefore, even WHO classifies them into 5 different groups. And the class 4 and 5 are basically clinically non-significant. But the classes 1 to 3 show different degrees of severity. So the class 1, class 2, class 3, class 1, for instance, is the most severe, which is the Mediterranean type. And so even as for them, when they even eat the fava beans, they will have a reaction immediately. And then we have the G6PD A plus, G6PD A minus, and the A minus, we have it among Africans and Asians. And the third class, which is also a G6PD A minus, is found among those in the Mediterranean places.
Okay. Dr. Anyimedu, about how common is it? Is it very common in our setting, like in Ghana, Africa?
Yes, it's quite common. So you just mentioned that the most severe type is found mostly in the Mediterranean areas. So you realize that Mediterranean areas amongst blacks, amongst Asians, that is where the epidemiology runs through, and you see it more common amongst these places. Some people will also say that it runs along the same areas where malaria is quite predominant. That is how common it is.
Okay, right. But how do I get it? Is it just by being born with it? Or can I inherit it, or maybe like get it from maybe an insect bite or something else?
Okay, no, that's what Dr. Adepa said, that it is hereditary. So what we'll call X-linked recessive. Okay. Usually when we say recessive gene, you expect that one parent gives you one, the other parent gives you the other. Then the two of them coming together will help you express the genotype into the physical manifestation.
Okay.
Do you understand? That's what we call recessive. But in this particular situation, it is sitting on just the X chromosome, and that is the reason why it is more common in males, because, as you said, for the male we have just one S chromosome and a Y chromosome. So the moment you inherit defective gene on the X, it means that you are expressing it phenotypically. You understand? So you see that it usually runs along the maternal side. So uncle, nephew, then it goes that way. It's just common like the way we have hemophilia and the others.
Yeah. So you said that some people or most people are asymptomatic, but if someone has symptoms, what possible symptoms could they show, Dr. Midwe?
Okay, so it generally runs from being largely asymptomatic to when you have the severe form of the hemolytic diseases. Okay. So when I say hemolytic diseases, I mean when your red blood cell breaks down. Okay. For some people, they are largely asymptomatic, but they begin to express tiredness, palpitations, especially when the anemia from the hemolysis take place. The same hemolysis will now give them the characteristic that coloration of their urine, as well as their eyes becomes yellow, and because the blood levels are also low, they get tired on the least thing they do, because the amount of blood in their body is reduced from the hemolysis that is taking place.
But why are they hemolyzing, Dr.
Yeah, so you see, so let's go to first principles. Now, all cells in the body have nuclei. Okay. Except, of course, the platelets and the red blood cells when they mature. But the red blood cells also when they begin forming in the bone marrow, they have nuclei. Okay. So,
example, let me stop you there. You can simplify it.
Yes.
So what's like, the RBC?
So every cell in their beginning stage, they are living. Okay. They are living things. So every living thing has a powerhouse. Okay. We call it the nucleus of the cell. Okay. And from that nucleus, they are able to derive their energy, right, by preparing food in a certain way. So, for instance, the way the body generates its energy is by aerobic respiration. So, like they breathe in the presence of oxygen, they are able to prepare their food to generate the energy they need, which is ATP. Okay. But, so in the process of generation, they can also have some byproducts that are toxic to the cell or to the body. Okay. So all the cells that have the nucleus have a way of producing something we call antioxidants, which break down those toxic substances. Okay. So like superoxides, free radicals in the body. Okay. But when red blood cells mature, they lose their nucleus. Okay. They lose that powerhouse that is able to make them the energy because of the hemoglobin, because the hemoglobin must fill the whole cell so that they will be able to carry oxygen to the other parts of the body. Okay. And that becomes detrimental to the red cell. So God has made it in such a way that even though the red blood cell loses the nucleus, it has a different way of stopping those toxic substances, which is the presence of the G6PD activity. Okay. So now the G6PD activity in the red blood cell causes the reduction of something we call NADP into NADPH. Now that will stabilize, that is supposed to stabilize another chemical called glutathione.
Okay, there's a lot of science.
So if that stabilization doesn't occur in the red cell, then the red cell is in trouble. Okay. So what the G6PD does in a nutshell is that it protects the cell's integrity and causes it to live its full lifespan. Okay. So unfortunately, those who lack the G6PD activity are always in trouble when they take a medication or a type of food that will cause the production of those toxic substances. Because now you have given the toxic substances a free ticket to act and destroy the red blood cells. And it sometimes can be very devastating.
Let me just add this. I just hope that maybe I'll arise the interest in biochemistry. So we call something glucose.
Yes, glucose.
And we call something phosphates, which are common.
Mm-hmm.
The DNA body is made up the phosphate backbone and the sugar aspect. Okay.
Mm-hmm.
So when I say DNA, I'm sure most of us have heard purine and what? Pyrimidine. So it may interest you to know that the pathway that produces the purine and the pyrimidine is the pathway we are talking about, the pentose phosphate
pathway.
Okay.
Do you understand? And it begins with...
we don't understand.
This pathway begins with glucose being phosphate being attached to
the glucose.
Okay.
And that's the first part that initiates this pathway to take place for us to get the DNA that what we know. I hope you all understand. Now, for you to get the glucose and the phosphates together, you need an enzyme.
Okay.
And the enzyme in question we are talking about here is the G6PD.
Okay. Yes. Okay. Thank you for that clarification.
So just to buttress what he said, that enzyme is supposed to speed up the reaction. It doesn't necessarily have to participate in it, but it only speeds up the reaction and makes sure that the red cell integrity is intact at the end of the day.
Okay.
In the process of doing that, you have they give a byproduct, which is the NADP that he mentioned, and the responsibility of that NADP is supposed to keep glutathione reduced, and that is supposed to prevent the oxidative stress that affects the red blood cells and breaks them down.
Okay, you're not speaking English to us, but is there any particular age at which someone might show signs or symptoms of this deficiency in the enzyme?
No, it can even start from the neonatal period.
Okay.
So that is why every child that has neonatal jaundice, born just a few days and has jaundice, G6PD is one of the tests that are done in those children who are supposed to undergo phototherapy or exchange transfusion to see what really is causing the hemolysis. So apart from the G6PD deficiency, the other causes of hemolysis in children could be blood group incompatibility. So the blood group of the child and the mother are also taken. So people who have undergone that, especially the premature babies and even term babies that get neonatal jaundice, these are some of the things that are done for them. So at every age, once you are G6PD deficient, anything that causes oxidative stress, like I said, those byproducts that are toxic to the body and can cause destruction of the red cells, they can occur in any age.
Okay.
So practically what we will see is that most mothers will come to the hospital and they'll complain that my child, or I've given birth, and by day one of the day one, they realize that the baby's eyes are yellow. So we are saying that the one of the causes of the yellowish discoloration of the eye in fresh babies is G6PD deficiency.
Okay. But what does the test involve? Is it a blood test, a urine test? What kind of test is it?
Yes. So basically, we do what we call a blood film, and the blood film is supposed to pick what we call the Heinz bodies. Yes.
The Heinz bodies are actually denatured cells. So when the hematologist sees denatured cells in the blood film, he will suspect a G6PD deficiency. And so he orders for the G6PD test to be done. There's a qualitative test and a quantitative test. And I think the quantitative test now has become the gold standard because it is able to pick up even the G6PD deficiency, even in an acute phase. But there's the likelihood of a false negative test of the qualitative test during an acute phase. So usually the acute test, which is predominant in Ghana, in many of the labs in Ghana, they are done when the people are in remission. So for instance, when the people appear asymptomatic, that you can do the test. The way they do it is they will mimic the pentose phosphate pathway in the lab, and then they show it against a fluorescent, against light. And if the blood fails to fluoresce, then it means there's G6PD deficiency.
Okay.
Yeah.
Right.
But the quantitative one, they will take the blood, run it on a machine, program it in a way, and it generates numbers.
Okay.
So there's a reference range. So if they find out that the number is smaller than the reference range, then there is G6PD deficiency. Okay. And I think that is better because no matter the stage, once the number is less, you know specifically. But as for the qualitative one, it is subject to the person's eye, and there could be reader errors and all that. So that is why sometimes you have these disparities. Somebody says, I was diagnosed at a particular lab as G6PD positive, and then, or the G6PD defective, and at a point I am diagnosed as G6PD negative. That is, especially happens with a woman, because they can be negative if, one of the, they have XX, right? So one of the X is, let's say, inactive. So it does not compensate for the other one. Then they show it. But even if both are active, you may not know whether one is inactive or one is compensating for the other. So we report them as partially defective G6PD.
Okay. So I've done the test and I have the deficiency. Can I donate blood?
Oh yes, you can donate blood. There is nothing wrong with blood donation. But once we know your record, then it means that we are not going to, the one who takes your blood, we're not going to give that person certain medications for the period. Because every blood cell has a lifespan, every red blood cell has a lifespan of 90 to 120 days. So when the blood is taken from you today, it is preserved in the bag for that period. Then it is it expires. So as long as it is viable and can be transfused, once it is given to the patient or the recipient, then we are not going to give certain medications that will cause hemolysis in that patient. But after that, he is free to take those medications again.
The other caution, the advice that we give to clinicians who are transfusing is that you also have to make sure that the individual who you are transfusing is not also G6PD deficient. So for example, if you are giving a G6PD deficient blood to a patient who is also G6PD deficient, you are complicating matters. But if the person does not have it, you can give it after all. By 90 or 120 days, the blood would have been wiped off, and new ones would have been formed.
Right. So what are some of these medications that can cause hemolysis in people with the deficiency, Dr. Anima?
Okay. The most common ones are what usually we say sulfur-containing medication. So for the pregnant women, there's a common medication that you take during your antenatal care visits. The SPs. So those ones are there. We have Septrin as well, which is a common medication is there on the market. Common paracetamol, interestingly, can even cause that. Ibuprofen can cause that. Even aspirin can cause that. Chloramphenicol. So these are even examples which are very readily available over the counter. That is why we also encourage patients that you don't just pick any medication and take it without any authorization from a prescriber, because you may not know your status. You pick the medications and you may start having side effects. And in our practice, I'm sure we've all seen such examples every time. So you have to be in the known and know the medication that you can stay away with. What usually practically we do in the consulting rooms is that we give you a card or red alerts, we pick your folder, we write you boldly with red pen. Some places they will give you a card and they will tell you that anytime you visit the card, and even including the ID cards that you put in your wallet, there should be something that tells anybody who picks you up that you are G6PD deficient, so that those medications can be avoided.
It's
very interesting how these days we find you know, especially in religious settings, we find armbands of, you know, Jesus is Lord and all that. But our health status, we don't. So elsewhere in the US, UK, all those places, you find people who are G6PD defective have bracelets.
Yeah.
So just in case the person collapses, you know, interestingly, hypoglycemia, people who have diabetes, DKA is a trigger for G6PD hemolysis.
Oh, I see.
Hypoglycemia is a trigger for, so somebody who has hypoglycemia, comatose, immediately you pick that person in a rescue effort. The arm bracelet will quickly alert the rescuers to know that let's not give, because certain anesthetic medications can also trigger. In fact, do you know vitamin C? A very high dose of vitamin C can trigger hemolysis. So G6PD defective patients, even though vitamin C is an antioxidant in its low state, which helps to, you know, keep the integrity of the red cell intact, when you give it an overdose, you know, in the times of COVID, we gave more than 1 gram of vitamin C daily. To the G6PD person, that can be a trigger for hemolysis.
Okay, I see.
But these are things that are not common to the red blood cells.
Yes.
So in the absence of G6PD, you end up causing stress on the red blood cells, and then hemolysis will
just break down.
Yeah. And then there are also some foods they can take.
Exactly.
What are some of these foods?
In fact, red wine is the first on the list of triggers for G6PD hemolysis.
Okay.
So for G6PD defective patients, red wine is a no-no. Now, beans, the fava beans, so all the leguminous plants, you have to avoid them. Soya beans, peanuts, the beans. So somebody takes peanut butter and then he begins to react. That person is likely to be a G6PD defective person.
Yeah.
And so it may be so minimal that he might ignore it.
Yeah.
Those reactions or those allergies might be minimal that they might ignore it, because it depends on the severity of the G6PD deficiency. So they might ignore it. But then some people, it can even trigger breathlessness, discomfort, you know, exertional dyspnea, what we say, those things. So blueberries are a no-no for a G6PD defective person.
Okay. And one common item at home that triggers a lot of the hemolysis from G6PD is naphthalene bulb.
Yeah, camphor.
And we all have it in our homes. So if you know you are G6, if you are watching and you know you are G6PD positive and you have camphor in the house, you need to be on the lookout.
Yes. Because the camphor is sublimes.
Yeah.
You know, that's the way it reduces inside. You put it here today, by tomorrow it's gone.
Yeah.
And that is how it fills the room. But that vapor, once it gets in, you breathe it in, that triggers the G6PD. In fact, we've had a lot of patients who the only trigger we identified as the cause of the G6PD is or was naphthalene balls that they kept in their things. And that also has been a cause of jaundice in children, because mothers like to keep their children's item fresh. But introduction of naphthalene balls and certain soaps, bath soaps that are very scenty, can trigger the G6PD deficiency. The others are herbal medications, herbal preparations. Very, very dangerous for a G6PD person. So once you're going to pick up your over-the-counter medications, especially the herbal preparations whose dosages we don't know, you need to be cautious of that.
So we've mentioned antimalarials as like one of the main triggers for. Are there alternatives for people with G6PD deficiency?
Yes, there are alternatives for people with G6PD. That is why you need to have a doctor who knows your medical history, that you are G6PD defective, so that he will give you the antimalarial that, because all the quinine antimalarials are not good for G6PD defective people. Quinine, primaquine, chloroquine, all those ones, even though they are very good malaria for malaria treatments, they are not good for G6PD defective people. Yeah. So that is why in pregnancy, actually, severe malaria in pregnancy, we used to give them quinine, but we have stopped and we are now giving a test unit. So that's one of the reasons. Yes. Apart from the fact that the quinine can induce hypoglycemia if you don't manage it well, it can also trigger hemolysis in a G6PD defective person.
Dr. Animido, you're saying something?
Yes, I was saying that there are several classes of anti-malaria. So if you are G6PD positive and you do not go to the pharmacy to get your own medication, during the history taken at the clinic, one of the questions we ask you if you have any medical condition, if you have any paramedical condition, and those information we gather from you helps us to determine which class of anti-malaria we should give to you.
Yeah, right. So you know how sickle cell is important when we are talking about marriage. Is it the same for G6PD?
Not really. Like I said, once you are able to avoid what we tell you, because over 10% of the black population is G6PD defective, and if you take the epidemiologic values, it's about 10 to 25% for the areas we have mentioned, Asia, Mediterranean, and all that. There are so many of these other deficiencies that you do not want to include them in the marriage list, because they do not cause lifelong disabilities. As it's only the consequences. For instance, if you have chronic hemolysis as a result of G6PD deficiency, which may have happened in the gentleman, because 6 months is a long time that if he was having hemolysis could have induced acute kidney injury because of the dark colored urine, which would have caused an acute kidney injury, and if that was not also managed, could have led to a chronic kidney injury and finally end-stage renal disease. So those are the things. But generally, G6PD deficiency will not be something that should be included or cause the break between couples, would-be couples.
If I could recall, I think sickle cell is supposed to be autosomal recessive. That means you need both parents to help express it, the characteristic physically. But as we mentioned earlier, G6PD is excellent. So you just need just a inheritance from one parent.
But does having the deficiency predispose you to other conditions?
Yes, maybe anemia.
It predisposes you to chronic anemia. And chronic anemia, if not managed properly, may lead to other conditions like heart failure. In fact, G6PD defective people are predisposed to diabetes mellitus, for instance, like I said. G6PD deficiency is actually also a predisposing factor for COVID-19 and long COVID. Research has shown that G6PD defective people are more likely to get COVID-19 and long COVID or the long-term consequences of or sequelae of COVID than non-G6PD defective people.
So we mentioned that it's not a disease, right? It's the defect. But is there any role for vaccination against this defect?
No, as of now, there's no vaccination for G6PD.
No. Actually, G6PD deficiency, because of the areas of endemicity that we find it actually confers some form of immunity against malaria. So actually, G6PD defective people seldom get malaria. And it's just like carriers of the sickle cell gene, AS people also have some conferment of immunity against malaria. But that is basically what it does. I'm sure it's because of, possibly it's the mutation of the gene is as a result of the endemicity of malaria that is present. Maybe the body is also trying to, you know, do something for
protect itself.
To protect the people.
Yeah.
However, the consequences of taking other food, medications, I'm sure God is wise, and that is why He prescribed certain foods for certain groups of people to prevent some of these things from happening, because actually JCSPD might be a good gene because it confers some protection against malaria, but indiscriminate dieting and medications and other things may trigger the negative effects of JCSPD and thereby leading to certain dire consequences.
But can it be prevented? Can it be prevented?
It is not. You can't be prevented. It's hereditary. But what the prevention you are talking about, you can prevent the hemolysis from taking
place. But not getting the effect. Okay. But for someone having, say, the chronic hemolysis, what can be done about it?
So know your triggers.
Okay.
Know your triggers. The medications that you're supposed to stay away from. Know the foods you are supposed to stay off. If there are other stressors, know those ones and stay away from them. And aside that, because of the frequent anemia are going to get along the line, you can also put yourself on this hematinics, or what we call blood tonics, so that every time your body will be in the constant production of red blood cells. Hemoglobin, sorry.
Right.
A very good and cheap medication that JCSPD and everybody to be on is folic acid. A daily dose of folic acid should keep you in shape and in good shape as a JCSPD defective person, to prevent the hemolysis from happening, because you are all the time causing the bone marrow to produce new cells which replace the old ones, and therefore even if there's a trigger that will cause the hemolysis, it's going to be a 50-50. You have a balance of hemoglobin destruction and production. The balance is adequate. It is when the balance is inadequate, especially in neonates whose liver is immature and bone marrow are immature to produce new cells as much as it's being destroyed, then the effects of the jaundice is very dire. It may go into the brain, cause kernicterus, and then that child may become mentally retarded for life. Even when that happens among adults, like I said, when the urine becomes cola-like, then as the kidney tries to get rid of it, then acute kidney injury may set in. So these are some of the things that we can do to prevent that from happening.
Okay.
I think folic acid is supposed to be the drug of choice.
Yes, it's the drug of choice.
You're interested in it. The same folate is needed in the pathway we are talking
exactly.
about.
Yes. So folic acid is cheap, but it's very, very important in the prevention of JCSPD crisis.
So this has been very interesting, but we'll go for a quick commercial break, and when we get back, we'll continue with our conversation. Please stay tuned.
Jesus started with prayer.
And he ended with prayer.
Prayer is not a monologue. It's actually a conversation with a creator, God. And that's how we serve you.
So we invite you to join us on Let's Pray, a service where you don't pray alone, here on Hope TV Ghana.
Let's Pray, a place where you don't pray alone. Showing Tuesdays at 6 p.m. only on Hope Channel Ghana, your preferred Christian TV station.
And good evening. It's another beautiful Tuesday, and I am so delighted to come into your homes again. My name is Afia Sewa Mansa, and you are watching Love at Home.
Appreciate the person. You want to be with the person. You want to talk to the person. Draw closer to the person. everything about a person looks good to you. At this point in time, we are saying that you are falling in love with such individual because there are many of them, but this particular individual is unique to you. So when we are feeling these intense emotions towards the person, then we are saying that love has started.
Once you feel this strong affection, security, completeness around a person, once you're able to unearth that person you feel these things towards, then it means you are in love. And you surely feel butterflies in your tummy.
Welcome back to the consulting room. We're talking all about G6PD. I hope you're learning a lot and it's simple enough for you to understand and remember. So in our setting as Ghanaians, we're eating a lot of leafy vegetables, greens. Does that have any impact on someone who has G6PD deficiency? Is there a trigger?
Some of our I mean, if these leafy vegetables come from leguminous plants, they may be a trigger for G6PD deficiency. We have already gone through the types of foods that a G6PD defective person may not, eat. But generally, any food, what I want to talk about is many times people take foods and get certain allergies, and they may ignore them, but it is important to come to the hospital and report any allergy resulting from food, because that may be a trigger for a G6PD deficiency crisis. So that when the investigation is done and the probe, we probe further into that, we may be able to catch what the reason is and then give you further advice on what to do to avoid that allergy. It may mean nothing, but when you come to the hospital and report it, it's very important that these tests will be done and then you are told what to do and what to avoid. Yeah.
But can I just walk into a facility and get my G6PD status checked?
Yes.
Yes, why not?
Why not?
Okay.
So it should even be part of our possibly yearly routine tests because it's done once.
Yeah.
That's why you need a certified lab to do it for you once, because when you are G6PD defective, it is a result for life.
Okay.
So you should do it in a certified lab, and possibly a doctor might request it for you as part of your routine tests and recommend the lab that you should do it in, so that the result that is generated is authentic.
Yeah.
And because that result is something the doctor is going to base on to advise you as to, like I said, what to avoid and what to eat going forward.
Yeah.
Just to add to it, just knowing the importance of it, it is not strange that during our antenatal care screenings, G6PD is part of the pre-pregnancy labs that are requested, because you may not know, it helps the mother during the entire pregnancy period, and as well when the baby is also born.
Okay.
Yeah, because the SP, the malaria medication here in our setting, malaria is very endemic.
Yeah.
People get miscarriage as a result of malaria infection in pregnancy. So it is one of the ways we prevent malaria in pregnancy. Very important antenatal service delivery.
Yeah.
So the medication that is given, very cheap, and it must be taken in front of the nurse. But it's a sulfur drug. So before that medication is given, it must be given, I think, from the second trimester. The mother must take it, I think, thrice or so before the delivery period. So once you are J6PD deficient, then a substitute is given to you so that that particular one does not cause hemolysis in the mother. Now, but if you are J6PD, you know, normal, your J6PD level is normal, then they can give you that medication without any effects on you. So that's why it is very important that before the medications, once you report at the antenatal clinic, J6PD is done in preparation for your second trimester when you start receiving the SP.
But these triggers, the food and medications, do they affect people with both the partial and then the food effects?
J6PD? Certainly, yes. But the severity will show how
the severity will be different. So that is why, and like I said, the WHO classes, you know, class 4 and 5 are significant. So they may have symptoms, but very minimal. So they sometimes ignore it. But the severe ones, class 1, 2, and 3, you know, they may have obvious, you know, effects of the, and they may be even hospitalized for a few days before they are, you know, discharged. So that is the severity. It comes from you know, the severity of the disease. I mean, of the disorder itself.
Okay. So for someone who has been exposed to any of these triggers and has come to the hospital, what might be done for them?
So they are treated symptomatically. So if it's anemia, for instance, so if it is the hemolysis that, and we know that it is a particular medication that is causing it, first of all, you need to stop the medication. So you need to stop the trigger. And once you stop the trigger, then now you tackle the symptoms as they come. If there is fever, you treat the fever. If there is, you know, the anemia, you treat anemia. In children, for instance, if the bilirubin is too high for phototherapy, we do exchange transfusion so that you can save the child and prevent the bilirubin from going into the brain.
What's bilirubin?
The bilirubin is the yellowing of you know, the yellow coloration of the blood from the destruction of the red cell. So that cannot go into the brain of the child because it may cause brain damage in the child. So you do exchange transfusion quickly. For the adults, you might also need to treat the other symptoms. If there is palpitation, if there is heart failure, you might want to also give IV fluids to cause the you know, the bilirubin to be diluted, so such that kidney injury does not occur and all that. You might also want to give medication that will stop the ongoing effects of the you know, free radicals that would have caused the destruction of the red cells. If need be, blood level or hemoglobin level is too low, the person might need transfusion immediately. So you treat the symptoms of the disease. But first of all, you need to stop the trigger from continuing.
Dr. Anima, I've got a medication. How do I know that it has sulfur in it?
Usually ask your pharmacist. One, make sure you don't buy medication without a prescription. Because over the counter, you may not know what the constituent of the medication you are buying is. 2, when you go to the pharmacy or a doctor writes a prescription, it is your right to ask the person what kind of medication it is, and seek answers from the individual that what are the side effects or what do I put myself in when I take these medications. Number 3, for those who can read, and even if you cannot read, pick the
The packaging.
The package there's always a sheet in the boxes. Take it and read and find out if there's something within it that may be important to you.
Yeah, right. So pregnancy itself is a stressful state. Can it trigger someone with the defect?
No.
Okay.
The stresses that will cause G6PD to happen usually come from, if it does not produce an oxidative stress, then it is not your kind of, maybe my husband is stressing me and things like that. Yes, I have worked too much and I'm tired.
Yeah,
those things cannot cause. But things that go into the body that will produce the free radicals we are talking about, the superoxides, the other free radicals, then that will cause the breakdown of the red blood cells.
Okay, right. So this has been really insightful. Thank you so much for coming. I'll take your final comments now. I'll start with Dr. Nimidu.
Okay, so what I have to say is that have it in mind that the red blood cells have stresses. And in the absence of G6PD, it may get exposed to certain stresses that will cause hemolysis to take place. So it is insightful for us to know our status so that we will be able to deal with those stresses and prevent future hemolysis.
All right, thank you. Dr. Hadapo.
Please know your G6PD status. It is very important. And if you do know your G6PD status, kindly get a doctor who knows the medical history. If possible, get a bracelet, get an armband. Sometimes when we are told that we have these things, let us not say tofiakwa. It is good to know so that you can even pray about it. Know what to do and what to avoid. Because to obey has always been better than to sacrifice, and to hearken better than the fat of rams.
Thank you so much. Viewers, you've heard it all. Know your G6PD status. If we are talking now and you don't know it, please make sure you are booking for an appointment or you are walking into a facility to get a check. It's very important. And for those who know it, when you go to the hospital, offer that information out freely. Don't hide it from your medical doctor or health practitioner. If they ask you, do you have any medical condition, tell them that you have G6PD deficiency. It makes a lot of difference what medications you'll be given. So thank you so much for joining us tonight, and we hope to see you again. Have a good night.